As we go to the third session of the day, may I invite the chairpersons to the next session. Professor Vageesh Ayyar, who is an endocrinologist, who will be giving us his views. Dr. Bhanuprakash HM, the cardiologist from Tumkur, and Dr. K. Srikanta, family physician from Bangalore. The next session will be on the cardiovascular continuum or to cardiometabolic care towards the integration of the concept of multi-organ protection. May I request the chairpersons to take over and conduct the session and invite the speakers.
Good morning. I think we have moved in a great way in managing diabetes and the cardiometabolic health, including renal. Initially, it was just a symptom control when it diagnosed in 1920s and the 40s. Then in the 80s, we moved to the glycemic control, mainly aiming at A1C control. Now we have progressed. It is not only glucose control is only a part of the management. It's an organ protection. So whenever we treat a person with diabetes, we need to protect his heart, his kidney, and also we have to control his glucose. Probably an era will come where we are heading towards the reversal of a diabetes with preventing the cardio, renal, and the metabolic. To speak on that, we have got two excellent speakers, Dr. Gopi and Dr. Girish Navasundi. These things are possible only because we have got two excellent molecules which got discovered in the past 2 decades. One was SGLT2 inhibitors, that's empagliflozin, dapagliflozin, and canagliflozin, and other being a GLP-1 receptor agonist. In fact, the role of these two agents are growing in a big way. Not only in a diabetes, they are in the field of cardiology, nephrology, even a gastroenterology. Here.
Yeah. Good morning, everybody. At the outset, I would like to thank the organizers for giving me this opportunity. Today's drug in focus is empagliflozin. For the normal glucose homeostasis, there is a complex interaction between the liver, the muscles, adipocytes, pancreas, and the neuroendocrine system. Of late, they have also identified the central role of kidneys in the normal glucose homeostasis. A significant amount of glucose gets reabsorbed in the proximal tubules. This was developed basically as an adaptive mechanism to maintain the body's energy requirements during fasting states. In diabetes mellitus, this response becomes maladaptive. So what does hyperglycemia do? Hyperglycemia augments the expression and activity of the sodium glucose co-transporter, which is responsible for reabsorbing the glucose on the proximal tubules. Now, in diabetics, there's almost a 20% increase of the SGLT2 receptors in patients with poorly controlled diabetes. Now, by controlling this hyperglycemia or this SGLT2 inhibitors, they improve the glucose control and reduce HbA1c. Not only that, inhibition of SGLT2 is independent of circulating insulin levels or insulin sensitivity, and hence, because of this, it is possible to combine the SGLT2 inhibitors with other anti-diabetic agents. Now, this is a pictorial of what normally happens. You find that in the proximal tubule, there are two receptors here, the SGLT2, SGLT1, and also the GLUT2 and 1. The SGLT2 is high capacity and low affinity, while the SGLT2-1 is low capacity and high affinity. 90% of the glucose reabsorption takes place because of the SGLT2 receptors and about 10% from the SGLT1. And as a result of this, in a normal individual, you would have minimal or no glucose excretion in the urine. Now, we compare that with patients who have got type 2 diabetes. Though the SGLT2 inhibitors, SGLT2 receptors cause a significant amount of reabsorption, but still you would get some amount of urine excretion, and that is how one of the methods used to diagnose diabetes mellitus. So, empagliflozin is a selective inhibitor of SGLT2. It causes dose-dependent urinary glucose excretion and can cause excretion of almost up to 80 to 100 grams per day. It's given orally, and no dose adjustment is required either in patients with renal or hepatic impairment, but should not be given if eGFR is less than 30 ml per minute per 1.73 millimeters square body surface area. As part of its effect, it also additionally causes a reduction in weight and blood pressure, and also reduces development and progression of heart failure. Today in the earlier lecture, and also what Dr. Vageesh was talking about, the concept of cardiac, kidney and metabolic management, I think this seems to be a right drug for us in this, to attain this goal. Now what happens in patients in whom we give SGLT2 inhibitors? So by blocking the SGLT2 transporter in the proximal tubule of hyperglycemic individuals, SGLT2 inhibitor increases glucosuria by as much as 80 to 100 grams per day, resulting in improved glycemic control and weight loss. So you see here, because of the absorption is blocked, you get increased glucose excretion, and as a result, it is one of the ways by which diabetes is managed in the situations. Now, what else? What other benefits do we have with empagliflozin? So, by glucose lowering, it reduces the microvascular morbidity, reduces glucotoxicity, and lowers the risk of hypoglycemia. Then, insulin-independent mechanisms are in play. It has ability to work at all stages of the disease, can be combined with other class of anti-hypoglycemics. It causes osmotic diuresis, basically because of its glycosuria and natriuresis. It increases the weight loss, and there's a decrease in blood pressure. Loss of excess calories in the urine as a result of it, sustained weight loss can be seen in these patients, and also there is a mitigation of weight loss which can be caused some other class of anti-hyperglycemics. Now, this improved hemodynamic parameters also leads to cardiorenal protection. So what does it do? In the kidney, it reduces the glucose and sodium reabsorption. As a result, there's an additional reduce in intraglomerular pressure, reduce intrarenal RAS activity, reduce hyperfiltration, and reduce inflammation hypoxia. So this, because of the glycosuria, diuresis, and natriuresis, from a circulation point of view, it reduces the plasma volume, it reduces arterial stiffness, it reduces systolic blood pressures, and increases the hematocrit. From the cardiac point of view, it reduces the cardiac preload and afterload, it reduces the cardiac wall stress, and increases cardiac efficiency and output. And all put together, there is cardiorenal protection. It increases cardiac function and increases the renal function. So the improved the clinical outcomes with this are, you have reduced cardiovascular outcomes, you have reduced heart failure hospitalizations, there's a stabilization of the eGFR, and reduction in albuminuria. Now, the key physiological effects of SGLT2 inhibition acts mainly because of glycosuria and natriuresis and osmotic diuresis. Because of glycosuria, it helps in reduction of HbA1c, in reducing glucotoxicity, in reducing insulin resistance. It tends to improve beta cell function and also reduces body weight. All of them combined give the glycemic effects of SGLT2 inhibitors. Now, the extraglycemic effects, mainly mediated by the natriuresis and osmotic diuresis, you have a reduced in plasma volume and also interstitial fluid. Compared to other diuretics, there is some mechanism by which it selectively has a little better effect on reducing interstitial volume as compared to plasma volume. Then it reduces the blood pressure, and it reduces glomerular hyperfiltration. All of these together combined, you get the metabolic, cardiovascular, and renal improvements. Now, for improving the renal outcome, the SGLT2 inhibition reduces what I've already told you, reduces the glomerular pressures, neurohormonal improvement, inflammation and fibrosis reduction takes place, decrease renal workload, and improvement in hypoxia. All these things, because of this, you get a stabilization of the eGFR, reduction in the blood pressure, reduction in the tubular and glomerular injury, and renal ischemic injury. Overall protection against diabetic nephropathy, and the renal function is better preserved in patients, either patients who do not have it, or also in patients in whom renal function is already impaired. This helps in preserving them to a longer time. Now, the extra clinical benefits of empagliflozin or SGLT inhibitor in general, you have weight reduction, blood pressure reduction, less hypoglycemia, cardiovascular safety and heart failure treatment, and renal and safety profiles. Now, some of the major trials which have given us all this information, you have the EMPA-REG outcome trial, where it was a study design which included 7,000 odd patients. Primary outcome was the risk of incidence and worsening of nephropathy compared to placebo. So kidney function, empagliflozin slowed the decline in kidney function as measured by estimated GFR. It reduces albuminuria, it reduced the blood pressure, and cardiovascular benefit. The trial confirmed the cardiovascular benefits of empagliflozin, which are closely linked to kidney function and safety profile. It was well tolerated with a safety profile consistent with previous studies. The study showed that there was significant reduction in primary endpoints, which were death from cardiovascular causes, non-fatal MI and non-fatal stroke by 14%, all-cause mortality by 32%, cardiovascular death by 38%, and hospitalization of heart failure by 35%. Again, this is in terms of renal outcome. Empagliflozin's renal protective effects are independent of concomitant medication that may alter renal hemodynamics. I already mentioned this. Then the other major trial which came from, I think it was the Emperor reduced trial. So this was a comparing of empagliflozin with placebo, and patients with chronic heart failure and reduced ejection fraction were randomized either with or without diabetes, and they were enriched for patients with left ventricular ejection fraction less than 30%. The primary outcomes were cardiovascular death and hospitalization for worsening heart failure. At the end of a little more than 2 years, they found that irrespective of the patient had diabetes or not, empagliflozin had a lower incidence of these primary outcomes, about 19.4% as compared to placebo, which was 24.7%. Most of this was driven by a lesser incidence of hospitalization for heart failure as compared to cardiovascular death. It also had kidney protection in terms of it reduced the drop in EGFR to significantly by about 0.55 in empagliflozin group compared to minus 2.28 in the placebo group. So overall, empagliflozin was in comparison to placebo had a lower risk in terms of cardiovascular death and hospitalized for heart failure, whether the patient had diabetes or not. The next trial was now to look at patients who had preserved LV function. It's a difficult scenario of patients for us to treat. We have limited drugs which are useful in them. So this was a multi-center randomized control trial incorporating about 6,000 patients with chronic heart failure, and LV ejection fraction had to be more than 40%. The endpoints were same cardiovascular death and hospitalization for heart failure. We found that there was a significant lesser reduction in patients who received empagliflozin as compared to placebo. Again, when you looked at secondary outcomes, both first and recurrent heart failure hospitalization was much lesser in patients who received empagliflozin, and also you had a much better preservation of the EGFR in patients who received empagliflozin as compared to placebo. Then, of course, the adverse effects with empagliflozin, because of its glycosuria, you have uncomplicated genital infections are more common, uncomplicated urinary tract infections are more common. Hypotension also is more common, especially in patients who are already hypovolemic and patients who are starving. These patients' hypertension could be a cause for concern. So overall, now the role of empagliflozin would be, you have them in patients who have got already established atherosclerotic cardiovascular disease, in patients who have heart failure as a prominent symptom, in patients who have renal dysfunctions, and also as in high-risk patients who do not have this already, for primary prevention for atherosclerotic cardiovascular disease, heart failure, or for chronic kidney disease. So it reduces heart failure and improves the renal protection. The side effects of these drugs: hypotension, ketoacidosis. You have a concept called as euglycemic ketoacidosis. Patients are more common with this drug, because one thing is, because of there is less of glycosuria and less of glucose absorption from the proximal. Some of the side effects or the markers of diabetic ketosis may not be as easily perceptible. So these patients can come to us with this euglycemic ketoacidosis. Acute kidney failure and impairment of renal function in few patients. Urosubsequent pyelonephritis, not uncommon. Hypoglycemia with concomitant use with insulin secretagogues. Genital mycotic infections. Increased LDL cholesterol. And then contraindications are serious hypersensitivity to empagliflozin, severe renal impairment, end-stage renal disease, or dialysis. In terms of guidelines from a diabetic standpoint, to achieve glycemic control and weight management goals in patients with type 2 diabetes mellitus, SGLT2 inhibitors are recommended. Type 2 diabetes mellitus patients having cardiovascular issues, heart failure, CKD risks are recommended to be initiated on SGLT2 inhibitors and in combinations with SGLT2 inhibitors. For heart failure with reduced ejection fraction, presently it has a class 1A recommendation. In patients with mid-range heart failure, you have a class 2A recommendation, and patients with preserved ejection fraction, again we have a class 2A recommendation. And so with this, with all this data that is available with about SGLT2 inhibitors and empagliflozin, it has become the fifth pillar for heart failure therapy. So in putting it in short, I think the role of SGLT2 inhibitors and empagliflozin in particular is with the concept of lifetime care, cardio, kidney and metabolic protection. I think empagliflozin or the SGLT inhibitors in general have a large role to play. Thank you.
Oh, you're in time. Thank you, Dr. Gopi. Be seated. I think we'll take up questions later.